the panel members, Professor Tuttle, Professor Gaitini, Professor Bachar, Dr. Nasrallah, Professor Shabtai, please. I will try to sound like Dr. Shaha now. Well, Mike, I am confused here. I got this beautiful lady enters my office. She's 20 years old. She has a 5 millimeter papillary carcinoma in her thyroid lobe. And I tell her, you need to have surgery here at Memorial, and I will do the operation. She comes back after 1 year. Now she is 21. She has 1.5 centimeter over half a centimeter positive lymph node in her lateral neck. And I tell her, okay, now you have neck metastasis, which is bigger. We're going to follow you. I'm confused now.
That's okay. That's why it's a multidisciplinary team. Endocrinologists are here to keep surgeons from being confused. His point is right? I mean, we get all excited because somebody has a 5 millimeter papillary. It becomes my Friday evening emergency consult before I'm flying to someplace nice. And then when they have recurrent disease, we go, don't worry about it. Right? That's a hard one to sell. So when in a 5 millimeter papillary, if she comes back a year later and has a 1.5 centimeter lymph node, that's a little bit unusual. But if that was a 1.5 centimeter lymph node, we would probably biopsy it and take it out. At less than 1 centimeter, then I have to sort of do the risk versus the benefit for her. And we really say, how much good am I going to do you? Somebody had on one of their slides, what's the goal of your treatment? What am I trying to accomplish? I'm not going to make you live 1 day longer. In many aspects, I used to say I want a highly sensitive TG assay and a really high-resolution ultrasound. I don't anymore. I want a bad TG assay, and I want an ultrasound that works like half the time. So that if you can't see stuff less than a centimeter, I'm fine. So what's changed over time is our realization that if you look hard enough, you find small volume disease. Not everybody can stand watching disease in the neck, as one of the speakers said. And if they can't stand it, we go to surgery and we take it out. I think the trend now in the ATA guidelines is going to be more slow down. Because I will tell you, even in some of the people that I want to watch, if I talk them into watching for 6 months or a year, I think you do a better surgery. Because we find not only the lymph nodes that are changing, but some that are a little outside that, and sometimes on the contralateral side. So even in those folks that I know are going to go to surgery, I go to Eyal's point and say, as long as you're not near a recurrent laryngeal nerve, as long as you're not near something really critical, let's watch for 6 months or a year. Let the weeds in the garden grow so that I can make the second surgery the last surgery and not do a second and a third surgery. So I find folks that won't contemplate watching for 100 years can sometimes understand that concept of not yet, and that eases them up a little bit.
Professor Gaitini, do we really need to do FNA on these nodes in order to know better what they are and to decide what is the next step for treatment?
Yeah, well, after listening to so many different opinions, I come back to our opinion, and I have to say that the size, we are speaking about lymph nodes, no? The size is not a good criterion. So if you have a small nodule, but it has characteristics of a malignant nodule, just like microcalcifications or a rounded shape, or sometimes cystic lesions inside the nodule. So even if it is a small nodule, I think that we will go to FNA to get a definitive diagnosis if this is a malignant or benign nodule. What you will do after is your decision. But
if we gonna Professor Bachar, if we gonna follow this patient, and we know that Dr. Gaitini did the ultrasound on the neck, and she found microcalcification, and usually she's right. Do we need to FNA this lymph node and maybe create more confusion or more stress to the patient? Or we can say, reassure the patient. What is your opinion?
Well, usually we will needle biopsy the lesion. Any suspicious lesion in the lateral neck or the central neck will be biopsied because first we are curious and the patient is curious. And if you won't do it, someone else will do it. It's also, we spoke during the break on it, it's a matter of culture. People are very stressed when they feel that they have cancer or they are very frightened about follow-up. So I do believe, in my practice, that I will needle any suspicious lesion, and then I will discuss with the patient the consequence of this answer, this result.
So I'll take the opposite view. If you're not going to do a surgery, don't stick a needle in my daughter's neck. It is much more difficult for me to talk a patient into watching a lymph node once it's biopsied. Even though I will tell them based on the ultrasound, I will take you to dinner if that's not thyroid cancer. It's got all the features. We're going to treat that like it's thyroid cancer. Psychologically, I find it a lot easier for the patient. I think they're hoping I'm wrong, but once it's biopsied, it's very difficult to watch them. So I actually teach our fellows, don't stick a needle into anything until you've talked to the surgeon. We have the discussion about, are we going to do a surgery, are we going to watch? If I'm going to watch, I tell the patient, I don't need a biopsy. I've made the decision to watch. So I come down fairly firmly on the side, which is in AL's paper, only about 20% of those were biopsied. We had all of those classic ultrasound features. So I think we have that discussion about whether we do it. If we send it to our radiologist, by definition, that means we want an answer. And so we had to work with our radiologist to say, no, don't stick a needle into it. Tell me you think it's cancer. Send the patient back to me. And then me and the surgeon in our group will decide if it's positive, would it make a difference in what we did? So I'm a big fan of not automatically biopsying. I teach my fellows, decide what you're going to do with that biopsy information first, and then decide if it's going to help you.
Professor Shabtai, one of the attending surgeons at Sloan that I was trained with always consent the patient, even patient for total thyroidectomy, for a possible prophylactic neck dissection. And he said that he can decide during the operation if there's a need to do a neck dissection or not. You're a very experienced surgeon. Do you think that we really can decide better than the ultrasound if there are lymph nodes in the central neck or not?
The answer is no. I think that the patient should know of the possibility that if, first of all, we have to, in the pre-op assessment, we do a high-resolution ultrasound, and if there is a radiological suspicious nodes or clinically suspicious nodes, or if we do find suspicious nodes during surgery, by looking at them, we can't really assess their true nature. And as Professor Talmi said, even if we take out a lymph node because it seems suspicious and send it to frozen section, we may have a sampling error. So I would, and this really strengthened the approach that surgery should be done by more or less experienced surgeons, that if the surgeon does indeed deem these lymph nodes highly suspicious, to do a prophylactic central, it's not prophylactic, it's therapeutic central lymph node dissection, but only then.
Professor Bachar, back to you. As a surgeon, we face the situation when a patient after total thyroidectomy come to us and she has or he has a positive lymph nodes in the lateral neck. Now, we operated the thyroid. We didn't do elective central neck dissection. Would you do in this case, again, to make life more simple, it's a low-risk patient, But the tumor, the lymph node laterally is big. It's 1.5 centimeter. Would you then do prophylactic central neck dissection, ipsilateral, bilateral, and put the patient at extra risk, obviously, because she had surgery in the central neck, but not prophylactic central neck, please?
Assuming the ultrasound, the pre-op ultrasound is negative for central suspicious nodes in the central neck dissection, the answer is no. I will not go back to the central neck. I will jeopardize the recurrent. I will jeopardize the parathyroid glands. I will not go back to the central neck if there are no lymph nodes, obvious suspicious lymph nodes.
Professor Gaitini, yeah, please.
I want to remark that the ultrasound has a very high sensitivity for lateral neck nodes, approaching the 80%. But when we speak about the central nodes, it lowers to 52, 55%. So the absence of ultrasound detected central nodes is not considered a proof that there are no central nodes.
Professor Tuttle, would you not do an elective neck dissection, but just open and search if there are positive lymph nodes below or behind the sternum?
Yeah, as a general rule, no. I don't do surgery. They don't give me sharp objects, but that doesn't prevent me from telling surgeons what to do. No, I think you stay out of those compartments so that if you have to go back again, you can go back again. I can tell you that's what happens in a lot of surgeries in the United States, especially the surgeons that say they don't do prophylactic neck dissection. They do very liberal use of frozen section, and they find some lymph nodes anterior to the nerve on one side or the other, and then once they find a positive node, then they feel like they can do a therapeutic neck dissection. So they will often say, I never do a prophylactic neck dissection, but in effect, that's almost what they're doing. So when you have this discussion, you got to ask the surgeon, are you doing lots of frozen sections of little lymph nodes, and that becomes your reason to clean out? And then they accept a higher risk of nerve and parathyroid because you've got real disease. My preference is to stay out of there totally, because I'm not convinced at all, for exactly the dormancy reason that Eyal showed you. They're there. Those lymph nodes are there. But we know they're there 50, 60% of the time, but yet the recurrence rate's 1 or 2%. And when you do the math and the number needed to treat, it's just not there. So in a big picture, I'd much rather go back on the few that need. The second part of it is many of the surgeons that say they're doing a prophylactic central neck dissection are not. It's ipsilateral. On the right side, they're not going deep to the nerve. They're not going into the mediastinum. They're doing glorified berry picking, and I think that's why we don't see a difference in the recurrence rates. If you were really cleaning that out, like a squamous cell carcinoma surgery, you could probably show a little difference in recurrence, but the price is too high. So for me, I think the price is too high to pay. The few that recur, we can find on the ultrasound, and I'll fight that battle another day. So I'd prefer you just stay out of that. Take the thyroid out and be done with it.
Dr. Nasrallah, this patient comes back after total thyroidectomy, and she has small lymph nodes in the central neck. Now, she wants treatment, but she is not sure if it's neck dissection or radioactive iodine. Now, she received already radioactive iodine, 150 millicurie. Is there a role for radioactive eye treatment after recurrent disease following initial failure for radioactive iodine to treatment of lymph nodes which are positive for papillary carcinoma?
I think that it depends on several factors. The most important factor that in this issue is the time from the first radioiodine treatment and the recurrence. That means if the time is just 1 year, that means the patient is not a radioiodine avid, and I will not treat her. But if the period is more than 2-3 years, I will try to treat her again with radioactive iodine treatment. I think that there is another several factors that must be taken into account: the biology of the tumor, the histology of the primary tumor, if the tumor is a PET scan avid or not. This biological markers like BRAF and like RAS that are a bad prognostic factor for metastasis, and lymphocytic infiltration, for example, that it is a good prognostic factor. Other factors that must be taken into account is if there is the lymph node, if there is extracapsular extension, the size of the lymph node itself. I think that taking into account all these parameters, we will decide if we have to treat this patient with radioiodine or not.
Now, I want to conclude it. I still have one question. I want a surgeon, Professor Shabtai, and an endocrinologist, Dr. Tuttle. A patient, which is around 40 years old, enters your clinic. Now, she has hoarse voice, and you scope her, she has vocal cord paralysis. Ultrasound and FNA shows papillary carcinoma, but it's isolated to one lobe. Now, she's young. You know that the vocal cord is paralyzed. What will be surgery, the initial surgery for this patient? Professor Shabtai.
Unilateral lobectomy of the affected side. I wouldn't go to the other side if the other side is totally normal in high resolution ultrasound. In fear of, as Professor Tuttle said before, if you do bilateral lobectomy and if your incidence of complications on one side is N, if you do a bilateral surgery, it's 2N, or 2X, actually. So it's times 2. So since however remote, the chance of injuring the other recurrent laryngeal nerve, this complication is of catastrophic dimensions. So I would do unilateral lobectomy and consider maybe ablation of the other side with radioactive iodine. And then radioactive iodine treatment.
So at Memorial, she would get a total, and it would worry the surgeons to death about being on the contralateral side. So they would clean out the disease on the right side. In a young person that already has a vocal cord paralyzed, this is going to be a bad tumor, and we're certainly going to want to use radioactive iodine. She's at risk for distant metastasis. So what would typically happen is they'd certainly take out whatever's on the ipsilateral side with the tumor and get that out of there. And then we almost always do surgery on the contralateral side. I will tell you it tends to be a little less than a total thyroidectomy on that other side. In a real total thyroidectomy, we see less than 1%. In a situation like this, we'll often see 4 or 5%. So while they still say they're doing an extra capsular total thyroidectomy on that contralateral side, it's clear to me they're being very careful around Barry's ligament and superior pole. So I think what really happens is a total on one side and almost a subtotal, or recognizing leaving a little bit behind on the other side. There are situations where it's like Hashimoto's thyroiditis and that other side is all scarred down, that they will stop with a lobectomy and will use radioactive iodine to kill the contralateral lobe. The ATA guidelines say it's not our preference to use radioactive iodine to kill the contralateral lobe, but it can certainly be done, and this is one of the classic situations where you do it. If I use radioactive iodine to kill the contralateral lobe, it usually takes 30 or 40 millicuries. It takes the lobe about 3 or 4 or 5 months to die, and then at that point, but the uptake is down to 3 or 4%, and then I do give ablation. So if you elect to leave the lobe behind, I'm not going to be able to really treat the metastatic disease for probably 6 months. So that's the trade-off we have to make. But in a young person, particularly if the only reason the nerve is involved, because this happened to be a posterior location of a 2-centimeter papillary, then I don't think I have to rush and do radioactive iodine. It's the location that got me in trouble, as opposed to a 4-centimeter mass plastered against the thyroid. So I think either approach works. We tend to be more toward total thyroidectomy up front and then to move to radioactive iodine.
Professor Bachar, what would they do in Toronto for not the 2 centimeters small? It's an aggressive tumor. It's a T4A. It infiltrates the nerve. The nerve is involved, probably muscle invasion. But the other side is normal. There's no tumor in the other side.
In Toronto and in Rabin Medical Center, we would do a total thyroidectomy. It will be done under intra-operative monitoring by a highly experienced surgeon, usually 2 surgeons. We'll work very slowly. We know what is at risk, but we want a total thyroidectomy. We probably will add radiation, and we want to follow up this patient carefully because this is not a regular papillary low-risk patient. We'll do a total thyroidectomy.
Thank you very much. Any other questions from the audience? Okay. Thank you very much. And